Hello, I'm Dr. Deed Harrison of Chiropractic Biophysics Technique and Chiropractic Biophysics Nonprofit, our spine research foundation. We've been going through these video research project reviews of each one of the CBP nonprofit peer-reviewed publications. Hopefully you've been following us on our YouTube channel. This week we're going through project number 44. It is actually a recent case study that was just published this last week in the Chiropractic Journal of Australia in 2017. The title of the paper is Restoration of Barefoot Gait in a 75-year-old Female with Cervical Spondylotic Myelopathy, a clinical case report utilizing Chiropractic Biophysics Technique, or CBP. The lead author on this project was my good friend, colleague, and researcher, Dr. Paul Oakley out of Canada, and then myself, Dr. Deed Harrison out of Eagle, Idaho. This was published, as I said, in the Chiropractic Journal of Australia, it's March 2017. And forgive the title up here, I forgot to edit that title. This is the actual title of the paper. To give a little background for those that may not be familiar, like if you're a patient or a lay person watching this presentation, what is cervical spondylotic myelopathy? Well, it's actually a neurologically driven entity consisting of cervical spinal cord symptoms and signs. People can have either no pain or they can have pain. So we can have neck pain associated with this. We can have arm pain, tingling, and numbness. It doesn't have to have a painful presentation. Typically what you'll notice is there's gait abnormalities, which are called long track signs. So we get pressure in the cervical spinal cord that affects the inside tracts of the spinal cord. So this is a cross section of a human cervical spine. This is what's called the cerebellum, or the back of the brain area. This is the brain stem. This is like your jaw, your face area up here. This is the top of the neck called C1. This is C2, C3, and then this is the spinal cord coming through. Now right here you'll see what we call cervical degenerative joint disease, or what's called cervical spondylosis. Now, when that gets significant, it starts to put pressure or shear load on the spinal cord. So you got to picture a shear, it's called a transverse load, into the spinal cord. It's not compression, okay? It's a shear load. Now that shear load, what it does is it creates internal shear stresses in the cross section of the spinal cord, and also longitudinal shearing in the spinal cord. Those shear stresses are greatest at the center of the cord. That starts to affect tracts in the spinal cord that are deep, and it happens to affect what's called the fasciculus gracilis that goes down to the legs. This is where people now get alteration in gait function because they lose motor control in the leg muscles. It's coming from their neck, but yet their feet are weak and floppy, their legs are weak and floppy, they trip, they fall. It's called cervical spondylotic myelopathy, okay? Now, this is driven by degenerative changes in the cervical spine over time. It obviously, the occurrence or the incidence develops as we age. It affects approximately 41 out of 1 million subjects, and that's an estimated incidence. Its prevalence at any point in time is 605 out of 1 million, and these are estimates in the United States populations. You might say, well, it's not that common. Well, it's common enough in older subjects. Again, the incidence and the point prevalence increases with age. Radiographic abnormalities can include elements of spinal canal narrowing. This can be by osteophytic activity or by true subluxation or displacement of the vertebra. Now, this is an older female's neck, not the female in this particular case, but you'll see here there's a lot of degeneration and destruction down in the lower cervical discs. There's no space there, and there's no space there. And then we have a lot of bone spurring and degenerative change going on in the ligaments. Here, this joint right here, you can see there's a big stair step. The back of the vertebra is shifted forward in front of the back of this vertebra. So C4 on C5 is what we call an anterior listhesis. Now that is a shear displacement of one vertebra on top of the next. Now that's traumatically induced or it's degenerative induced over time. So this can progress to the point that this will slowly start to displace after some type of past injury that didn't get managed properly, and we don't have proper strength and support of the musculature here. There's a subtle anterolisthesis at C3, C4, but 4 and 5 is very large. Now what that's going to do, it's going to put huge shear pressure on the spinal cord and the nerve roots in that region. So what happens is we get alteration in spine curvature, so an abnormal cervical curve. We get degenerative joint disease. We get changes in the ligaments and the muscles, and we get maybe an anterolisthesis, or what's called a backwards or retrolisthesis, and then this starts to put pressure and stretch on the spinal cord, leading to long tract signs. There's evidence to suggest that 20 to 60% of patients will deteriorate neurologically without surgical intervention. So the natural history of this thing is that it tends to get worse in certain populations. So you don't want to just go, oh, it's no big deal, it'll get better with time. Actually, no, it doesn't. It gets worse with time. This is one of those things like, oh, I'm 15 pounds overweight, I don't need to change my diet. Well, guess what? In 5 years, now you're 30 pounds overweight. This is the same issue. You gotta take action now. You start to see anything unusual in your body, don't wait, go in now. You're tripping for some reason, or your grip is weak, something's going on, don't wait. Don't sit there and go, oh, it'll get better. Guys, it won't get better. And you notice I called out the men, guys, because women tend not to be that stupid. Women will go in and go, hey doc, I got a problem. Guys, we tend to be really pig-headed. Forgive me, I'm a man, so I can say we tend to be stupid and ignorant about it. We go, oh, it'll get better with time. It doesn't get better with time. Listen to your wife, listen to your doctor, get in there and get it done. Okay? Surgically, we know that surgery does help this. However, the long-term outcomes of surgery may not be actually better than the short-term outcomes of surgery. However, the short-term outcomes of surgical intervention tend to be reasonably good when there's a proper indication for this surgical correction. Now, this paper comes in the journal from the Journal of Neurosurgery Spine in 2013. I want to show it because what they're identifying here is that reversal of the cervical curve at any segmental level is in fact correlated to poor outcomes, short-term and long-term, and actually it's correlated to the improvement of surgical outcomes when we correct that cervical kyphosis. So it says here the degree of cervical kyphotic correction correlates with improved neurological outcomes. So there's a positive relationship between attainment of global or total lordosis and improvement of these scores called the Modified Japanese Orthopedic Association scores for cervical spondylotic myelopathy and or radiculopathy. Spinal degenerative joint disease and pain and disability in older subjects with this condition. This comes from 2007, the Journal of Orthopedic Science. This is 79 patients that are older than 65 who have eventually had surgical treatment for CSM, cervical spondylotic myelopathy. Now, our patient case is 75. She would have been in this study as well, like she fits the inclusion for this. 24 or 30% of these subjects had in fact an anterior or posterior listhesis greater than 3.5 millimeters. Now that's about a third of the population has one of these shears in their cervical spine. Now that's a major component or contributing factor for the development and the progression of this disorder. Okay? 31 of these subjects had displacements between 2 and 3.4 millimeters, and then 24 had displacements less than 2 millimeters. So the reality of it is, if you take 31 and 24, now we've got the majority of our subjects have at least a 2 millimeter shear. This becomes highly significant. These authors conclude that anterolisthesis has the greatest impact on cervical spondylotic myelopathy, followed by retrolisthesis. This particular paper here, it's just a summary statement that I have from Spine 1998. They say disc protrusion, osteophytes, and retrolisthesis are a primary etiology in cervical spondylotic myelopathy. So now to our particular case. So number one, we're expecting this subject to be a little bit older when they present like this. In fact, this case is. A 75-year-old female could not actively walk barefoot, So with no shoes on to support the arch in a certain profile in the shoe, she couldn't walk. She had a history of falling. She had to use canes or walkers. She reported neck pain of interest, not all subjects do. She had a decreased range of motion in all directions in her cervical spine, and she had numbness down her arms, legs, and into her feet. She was previously diagnosed by multiple providers, including a neurologist with cervical spondylotic myelopathy, or CSM. When she came in, she rated her neck pain a 3 to a 6 out of 10, depending on the day. Some days it was a 3, some days it was up to 6. So a 6 is pretty close to severe, not quite. It's right at the cut between moderate and severe neck pain. She scored a 42% on the Neck Disability Index. Now, that's getting pretty high. So we're in the moderate range of neck disability from this condition. And then visually, all her range of motions were reduced. Now, here's her lateral cervical x-ray. Number one, you can see anterior head displacement or translation. The point here on C2 where the laser dot is should line up back here, which is vertically aligned with C7. So there's significant anterior head translation. There's also loss of the cervical curve, and then there's considerable degenerative joint disease in her lower neck. Now, the good news is she does not have an anterior listhesis like the majority of the population would have with this. This is actually good news. Anterior listheses tend to complicate the outcomes, okay? So we're gonna set the stage that this might actually be a better case outcome due to the fact she doesn't have a true displacement of a joint in her cervical spine. Positive Romberg sign. So she had balance disorders when standing on one leg or with her eyes closed on two legs. She would fall over. You try to get her to stand on one leg, she would immediately fall over, both with and without the eyes open, by the way. Multiple sensory disturbances to touch along the dermatomes in the legs and the arms, which are consistent with cervical spondylotic myelopathy at multiple levels. She had not driven a car in approximately 3 years due to lack of confidence and the numbness that she was presenting with. Now, this is good for her. Kudos for her. A lot of patients won't give up that privilege and the right to drive their motor vehicle. The reason is, hey, people need to get to and from places, grocery store, whatever it is. Without a vehicle, you're highly dependent on other people or public transport, which in the United States is not that great. Maybe in Canada where she lived it was okay, but in the United States I can tell you that the public transport system in most cities is not really that great. Okay, so she had not driven a car. She had seen multiple healthcare providers, including an MD and a neurologist and a physical therapist, with no change in her symptoms. In fact, her symptoms are progressing. This is an important part of this case. It's not that she just comes in and had tried nothing before chiropractic biophysics. She had come in and tried multiple things, including medication, physical rehabilitation with the PT, medication for the neurological problems with the neurologist, etc. She felt her condition had worsened over the last year, and again, this was confirmed by a neurologist that she does indeed have cervical spondylotic myelopathy. So what did we do different with Dr. Paul Oakley up in Canada? Well, we look at this and we go, what can we do that might improve the neurological signs and symptoms? You got to be careful with this condition. You can't do aggressive hyperextension maneuvers. Okay, you can't do classic CBP traction with weights because of the fact that her canal is narrow due to the degenerative changes that are going on in her cervical spine. But you can do some simple types of extension traction. You can do simple exercises to improve the cervical curve and try to open up the joint, and you can try to improve the head posture. So that's what's being done here. Let's do some exercises that are designed to do two things: translate the head posteriorly and also try to get a better cervical curve in this area of her neck without creating forced excessive hyperextension. Now, yes, there is some extension, but it's not hyperextension, okay? So we call these mirror image exercises. This is a tool that we sell to patients. You can get this through your CBP trained chiropractor. It's called the Lordotic exerciser. It's got to be done at the area that you want to improve the curve. And then this exercise equipment is typically done in the office. It's designed to improve the posture and the strength of the neck musculature. Also, mirror image adjusting was done. This is what the chiropractor will do with you on the table. Typically, we put the person prone, we translate their head backwards the best we can to their tolerance, and then we're going to thrust in at the apex of their cervical curve. Now again, we do have to be careful in this case with cervical spondylotic myelopathy because there's already a narrowing of the canal where the spinal cord is. So we may not get this aggressive. Obviously, this is not the patient. This is an example on a younger person that we're showing. With an older person that had canal narrowing, like our case here, we're going to do less aggressive extension, and we're going to use an instrument that applies very specifically located forces instead of grossly dispersed. Now, the force per unit area with this instrument is very similar to the force per unit area with this method by hand. It's just much more focused. We can control it a little bit better and make sure the person tolerates this before we progress to your head translation and loss of the cervical curve. The last thing we would do for the CBP approach is some type of cervical traction. You've got two choices. You've got the Denerol, which you can place in the lower cervical spine at the apex of the curve, or we've got the posture pump. Now, Paul in this case chose the posture pump because he could control how much pressure was going in there from the start. Okay, with the Denerol, it's a certain height every time. You just got to be able to lay over it, right? Whether you use the pediatric one, the mid-cervical one, or the large cervical one. In this case, Paul felt that the patient couldn't tolerate the size of the Denerol at first, so he started her on what's called the posture pump. The posture pump is an air bladder that you put in the low or the mid part of the neck, and the patient can pump it up to their tolerance very gently. Okay, so the reality of it is this would be done every time the person comes into the office, 3 or 4 days a week. You're going to start with 3 minutes per session, and you're going to build up to 10 to 20 minutes per session. Now, Paul stopped at 10 minutes on this just due to the cervical spondylotic myelopathy. Most cases, though, in the office, we would go up to 20 minutes. Paul stopped at 10 in this particular case study that we're talking about. Now, here's the outcome. This is after 26 total treatments. You can see the improvement in the head translation is very marked. You can also see the improvement in the cervical curvature. You can see that these lower cervical discs appear actually to be opening up. Okay? This is an important finding because in addition to the neck x-ray changing that was driven by the type of treatment we did, her signs and symptoms are improving. At this point, she's got no more neck pain, no more numbness, and she can walk barefoot when she couldn't do that without a cane or a walker. Okay, so here it is, the initial view, 35 millimeters of forward head translation. That's down to 21 millimeters, so a 14 millimeter change in head translation, approximately a 35% improvement. Also, the cervical curve went from 22 degrees to 33 degrees. So we've improved that cervical curve by 50% as well. Now, one other thing that the patient was doing, she was doing some balance and movement activities on the power plate, a whole body vibration plate. Paul had her do some simple step-ups and some lunges, holding on to the power plate tower while she was doing it, and then also taught her how to squat and do full movement range of motion squats once she was able to. Whole body vibration is a very important part of rehabilitation in these types of patients. They haven't been able to use their muscles appropriately, so the whole body vibration forces the body musculature to contract in a synchronized way due to the perturbations of the vibration itself. So that was being done as well. The outcome, the neck disability index went from the mid-40s down to a 0. That's a huge change in the neck disability. Again, she reported no neck pain. So she went from a 3 to a 6 out of 10 down to a 0 out of 10. Her neck flexibility and range of motion increased in all directions. She reported that she could walk again without shoes on. She had no more numbness and tingling down her arms and her legs. And now she's driving her car again for the first time in 3 years. You don't know how big of a deal this is to an older person that has lost their ability to go from point A to point B in their own vehicle. What a huge thing that this is for this woman. I mean, really, seriously, when you stop and think about that, everything else is great. I got no pain, I got no disability, but what can I now do in my life that I couldn't do before? That's the important thing. How we're improving and changing somebody's life through correcting their spine with properly done spine rehabilitation and chiropractic biophysics technique. This is what it's about. It's not about, oh, I got somebody's neck pain to go away. No, I gave them their freedom back. They can now walk again. They can drive their own vehicle again with confidence without worrying about causing an accident and injuring somebody else. She was able to perform the heel walk in all orthopedic tests. That's a great outcome. Now, why? Why do we have such an outcome? Well, the reality of it is it likely has to do with spinal cord biomechanics. When you lose your cervical curve, it's going to put longitudinal stress and strain, stretch on the spinal cord and the nerve roots. Okay? It goes from this picture here, where the spinal cord and vessels are nice and relaxed and the nerve roots are relaxed. It goes to tension when you lose that cervical curve and you shift forward. When you put tension on the spinal cord and then stick an osteophyte, a bone spur, a disc herniation, a calcified ligament into it, like is occurring with cervical spondylotic myelopathy, that shear load creates problems internally in the spinal cord. It doesn't work anymore. Nerves break down under load. They don't like it. They're not able to function right, they don't get proper oxygenation, and they're not able to produce what's called neurotransmitters, which are important for neurological function and activity. It's the only way that your brain can communicate to the rest of your body through the spinal cord. It's a high metabolic region, and if you put pressure and stretch on it, its ability to perform its metabolic activities, it doesn't work so good. The reality of it is, this is the mechanism we proposed is what is going on. When you rehabilitate the cervical curve and improve the posture, it takes the cervical cord from this position closer to this position, and now you get more exchange of oxygen and nutrients. Now the spinal cord can behave properly mechanically like it's supposed to do. That's the reality of what's happening, at least in our opinion. Conclusion. In total, the patient received 44 total treatments, including maintenance care after their examination over the course of about 5 months. Unfortunately, the patient then moved out of town. She was very happy with care, but she did move out of town and follow-up was lost. But we do have a follow-up of approximately 2.5 months after care in this particular case. We believe that increasing the cervical lordosis by extension traction decreases cord tension and the shear load by shortening the canal length. This relaxes the central nervous system, spinal cord, brainstem, cerebellum, and nerve roots, and it releases the intermittent impingement due to the spondylotic changes or degenerative joint changes in the neck that cause or contribute to these neurological signs and symptoms in this patient. The reality of it is this: not every patient will respond like this with cervical spondylotic myelopathy, but for a 75-year-old woman to have to undergo surgery, there's a risk of injury and compromise in these types of neurological interventions, especially the older we get. There's a risk, it's not huge, but some studies have said 2.5 to 7% risk of some type of injury and in rare cases death. You can look that up for yourself. One report I read said in some of these cases it's a 0.5% to a 2% death rate. Some of the studies have said 7.5% morbidity or impairment rate. So I look at this and I go, wouldn't it be of interest to try something conservatively effective first? If you do 2 to 3 or 4 months of conservative care and that fails, then you can go and undergo surgery. And obviously, you should know that there is a risk of surgery. You just read the fine print. I'm not making this up. You can review the literature here. I'm not bashing surgical outcomes for this. I think in many cases it's very important to undergo surgery. But I also think that in just as many cases, conservative care can help and should be the first line of treatment that we should pursue. Hopefully you enjoyed this presentation. I'm Dr. Deed Harrison of Chiropractic Biophysics Technique and Seminars. Hopefully you will consider, if you're a chiropractor, coming and learning CBP technique from us. If you're a patient out there, let's go to the CBP website. Let's look up CBP trained providers. Let's get people with or without cervical spondylotic myelopathy to a CBP trained doctor. They can look over your case and they can decide whether or not you're a candidate for our care. What do you have to lose? You can always undergo surgery afterwards. Till next time, I'm Dr. Dean Harrison.